Hello, everybody. It's a great pleasure and privilege to be here today on this session. Together with me is Professor Florian Lordig from the University Cancer Center Leipzig. And we will be presenting you the updates, the highlights of the ESMO conference that just took place in Madrid in October. My name is Zorana Maravic, and I'm the CEO of Digestive Cancers Europe, the European umbrella organization of 38 national member organizations coming from around Europe. Florian, welcome, and would you like to present yourself?
Thank you very much, Zorana. It's a pleasure to work with you again. I'm Florian Lordig. I'm based in Leipzig in Germany as a medical oncologist. We just returned from ESMO with some interesting data about advanced metastatic stomach cancer. And we picked up some of the studies to show you what is going on in stomach cancer, where progress is currently happening. And it's my pleasure again to work with you, Zorana, and with Digestive Cancer Europe to help patient and patient organizations to understand better where the progress currently takes place. The studies that I picked, some of them are really important and practice changing and went already into the change of guidelines. And the major motive here is that when it comes to the treatment of metastasis and of advanced stomach cancer, the patients should have the right that their cancer is well investigated. And I'm talking here about treatment targets, about biomarkers that should be known to make the treatment more effective. And I will show you here some of the examples, what we have seen at the ESMO Congress. Before I show you that, I disclose you here some collaborations with industry, mainly in the context of education or also scientific collaboration. And I show you a short disclaimer. And here I come to a first study, which is combining two more or less novel biological drugs with chemotherapy to fight against metastasis from stomach cancer. The one drug is called pembrolizumab. This is an immune checkpoint inhibitor, a drug that enhances the activity of the immune system of the sick person. And the other one is called trastuzumab. This is a relatively old biological drug, which is directed against HER2. This is a typical tumor protein, which is present in 15 to 20% of stomach cancer patients. This drug is also used a lot in breast cancer, where we also find an overexpression of HER2 in many of the cancers. So we are talking here about a so-called phase 3 trial. This is a trial that involved many patients who received either pembrolizumab plus trastuzumab and chemo, or placebo plus trastuzumab and chemo. So the objective of this trial was to see what the addition of pembrolizumab to what is currently regarded as standard of care is bringing in terms of response rate and also survival-related measurements. There was an interim analysis that was already published 2 years ago that showed that by the addition of pembrolizumab to trastuzumab and chemotherapy, much more patients achieved a response, 74% versus 52%. This led the FDA, which is the approval agency in North America, to approve this combination for treatment in patients. But this was not yet the case in Europe, because usually the European agency is more conservative. They wait longer. They want to see survival-related outcomes before they approve a new drug. Here is what was done, what was studied. 350 patients received pembrolizumab plus standard therapy consisting of trastuzumab and chemo. And another 348 patients received placebo and standard therapy. And you can see that an endpoint that we call progression-free survival was longer with pembrolizumab versus placebo and standard therapy. Progression-free survival is an important endpoint. It's the time a patient lives without that the tumor progresses, with a control of the tumor. We see that as an important point for patients to have a controlled tumor and, of course, to be alive. From this overall population, there was a subpopulation, approximately 85%, who additionally did not only have an expression of HER2, but also of PD-L1. This is another important biomarker. It's called programmed death ligand 1, and it gives a signal that this disease might be more sensible to immunotherapy. So when these 85% who had a PD-L1 overexpression received pembrolizumab instead of placebo and standard therapy, the increment in progression-free survival was even higher, 10.8 months versus 7.2 months. Once again, what was shown exactly in this study? Overall response rate was reported, which was higher with pembrolizumab than with placebo, 73% versus 60%. The duration of response, which is shown here, was higher with pembrolizumab than with chemo. And importantly, the complete response, so all metastases disappeared from the CTs or from the MRIs, was higher with pembrolizumab than with placebo and standard therapy. 17% in the experimental arm, pembrolizumab, achieved a complete response. These graphs here are showing you the difference in progression-free survival and in overall survival in the population that had HER2 positive tumors and PD-L1 positive tumors with a certain threshold that is given here. And you can see that these Kaplan-Meier curves, how we call that, clearly separate early, and they remain separated both with regard to progression-free survival, which is shown here, but also with regard to overall survival. So a clear improvement of survival-related outcomes for patients who received the combination of pembrolizumab and trastuzumab. So what are the conclusions here? First-line treatment in patients with advanced metastatic HER2-positive gastric or esophagogastric junction adenocarcinoma, notably in those patients who have both HER2 positivity and also PD-L1 positivity, benefited from the combination of pembrolizumab and trastuzumab in combination with chemo. They showed an improved progression-free survival. Also, at an early time point, improvements in overall survival were already shown, which may become even bigger after longer follow-up. And they showed improved response rates and durable responses. I didn't go into details about safety, but this combination proved to be safe and can be administered to patients from now on. Because the presentation of these data changed practice, this combination will be approved within Europe. We also changed our European guidelines, and we recommend now that pembrolizumab and trastuzumab are combined with chemotherapy in the population with HER2 and PD-L1 positive tumors. So what does it mean for practice? The HER2 status and the PD-L1 status of the cancer both must be assessed before the starting of first-line therapy. These parameters are important to prescribe optimal treatment for patients with advanced gastric or gastroesophageal junction cancer. This is the cancer that has appeared in the entrance region of the stomach. Pembrolizumab plus trastuzumab in addition to chemotherapy should now be the new standard for patients with HER2 and PD-L1 positive disease. It will be approved in Europe, and we recommended it in guidelines. Should we shortly discuss this study here, Zorana, before we move on with some other interesting aspects, other biomarkers, new treatments?
Definitely. I think this is a very interesting study, and thank you for presenting it in a simple language, a layman's language. From the patient perspective, this clearly shows the importance of patients understanding the impact of their tumor characterization on treatment. So I wanted to ask you from the practical point of view, from your practice, at what point a patient with metastatic gastric cancer is being tested for their biomarker status?
This is a very important question, and we do that from the beginning, before we start any chemotherapy or other treatment. And it's still not a very big number of biomarkers that should be tested. In stomach cancer, we are talking about 3 or 4. I will show you the examples for the other ones also in the next studies. It's simple tests. They are not very expensive. They can be done in every center or even community pathology, and it doesn't take a long time. It takes maybe 4 to 5 working days until the results are usually available. So this is simple. It should be done, and it influences treatment. It brings us to, I would say, the optimization of what we are usually doing. And I'm saying this with a lot of intention because, unfortunately, I still see many patients in our second opinion consultations, for instance, where this profile is not perfectly done for reasons that I cannot easily understand. It's available, it can be done, and it should be done.
I think this is a very important message for patients, that testing should be done before any treatment is started. And I wanted to ask you, because we work a lot with patients and we hear that this was not very well explained to them, the importance of biomarker testings and their impact on treatment. So how much time do you spend speaking to patients, making sure they understand why the testing is being done? And, you know, as you say, it is just couple of several working days, so it is not that they have to wait to start with the treatment, because this is often the fear that patients have. They don't want their treatment to be delayed. So how much time do you spend with them explaining the importance?
Yeah, this takes usually some time during the first and or second consultation. We really try to make patients aware that for selecting the optimal treatment from the beginning, an in-depth investigation of the tumor is important. And to to my impression, most patients understand that it's important for them to get the optimal treatment or the optimal treatment sequences. Often we tell them already from the beginning that maybe they will not only need one treatment at the beginning, maybe we will have to change treatment, and to shape the overall plan to maintain their quality of life, to maintain their survival as long as possible. It is important to understand the individual nature of their tumor. We explain them that not every stomach cancer is the same. They may have a different stomach cancer than the patient we have seen before or the patient we will see after them. And we take some time to explain them what we are doing. We often also give them a certain list of what we will be doing, a provisional medical report where we write already we are investigating now HER2, PD-L1, MSI, to shape the treatment according to the results, which will be available in a week from here.
And the last question, and I will now go back to the study that you have presented. So the patient population in the study very often has high burden of the disease and symptoms. And how do you see this treatment helping them? Do you observe improvements in the quality of life?
I think that's an extremely important point that especially when we are talking about stomach cancer and some other gastrointestinal cancers, many patients really feel their cancer. They have lost some weight, or they have abdominal pain, or they can't eat regularly. And one of the goals of the treatment that we are starting is not only that we prolong survival, which is also very important, but it's also that we are controlling symptoms, that we are reducing symptoms, or that we are prolonging the time until symptoms get worse. So there is certainly an influence on quality of life. It's not always, as physicians, it's not always so easy to measure quality of life scientifically because it's something very objective. But I can say for sure that the best sign for us, and something many patients report already at the next consultation when we started some chemotherapy or immunotherapy, is that they say, I feel some relief. I experience that I can swallow better, or that I'm gaining weight again. That is an optimal result, which of course has an influence on quality of life, because if eating is better, if social contacts can recover, if physical activity can be regained, that's really an important goal as well.
Okay, this is great to hear. And I think it's not just about quality of life, being able to do more of the regular activities, but this also helps them undergo treatment better, because if patients are malnourished and they're weak, I guess that sometimes even the treatment has to be delayed or the doses have to be reduced. So something also to keep in mind, the importance of patients being properly nourished.
I couldn't agree more, and this is also the reason why very often we involve our nutritionists to accompany the treatment. We often also prescribe some additional nutrition, especially in the beginning phase of the treatment, to augment the physical status of the patient. So all these things also count next to chemotherapy or to other tumor-targeted therapies. Of course, we also need to support patients in a complex way: nutrition, physical exercise, psychological support, etc.
Thank you. I suggest now that we move to the next study, because we have a lot to cover today.
Yeah, I will be maybe a bit faster when I'm showing you what else was going on. But to complete the picture, I also want to show you something where investigators tried to treat patients with advanced metastatic stomach cancer without chemotherapy. That's very interesting, because traditionally we always used chemotherapy over the past 20, 30 years to treat metastases. And here we are speaking about a form of stomach cancer which has the biomarker of microsatellite instability high, MSI high, which is very sensible to immunotherapy. So what investigators from Japan in this study did is that they combined two immune checkpoint inhibitors. One is called nivolumab, one is called ipilimumab. They have a bit of different mechanisms of action. Nivolumab is directed against PD-1, another biomarker. Ipilimumab is directed against CTLA-4. These are two proteins, two immune checkpoints, which play a very big role in the regulation of the immune system and in the ability of our immune system to fight against cancer. In this condition, microsatellite instability high, some mechanisms are different from other stomach cancers and make the disease much more sensible towards immunotherapy and these immune checkpoint inhibitors. This is something we know already, and here it was studied systematically. The colleagues, they screened for microsatellite instability high as a biomarker. And for those patients with advanced metastatic stomach cancer. Um, they offered them to become part of this study where they received nivolumab and a low dose of ipilimumab as a first-line therapy for their disease. And they reported about response rates and some other parameters. So what actually was given is nivolumab every 2 weeks and ipilimumab every 6 weeks. Ipilimumab in a relatively small dose, which is important because this combination can already be quite toxic in terms of inducing immune reactions, even against healthy organs. But with this smaller dose of ipilimumab, the risk for having unwanted immune reactions becomes much smaller. What they looked at is how many patients respond to that treatment, how many patients are controlled so that the disease is not getting more, how long does the time until the treatment progresses take, and also overall survival was an endpoint of this study. And you see here a big list of technical observations which they made. It's still a small study. Only 29 patients were included, while more than 900 patients were screened. This shows you that this biomarker, microsatellite instability, is not found very frequently. It's found in less than 5% of the patients that we screen for it, but nevertheless, it's important to look at it because this is a completely different form of stomach cancer, which can be treated differently, as you can see here. Of these 29 patients, 3 experienced a complete response. So all the disease disappeared from all the pictures, all the imaging that was done. More than half of them, additionally, to the 3 that had a complete response, had a partial response. So objectively, the metastasis shrinked, became much smaller. This sums up to an objective response rate of 62.1% without any chemo. Traditionally, we would have treated all these patients with chemotherapy. Here they were treated without chemotherapy and nevertheless achieved a response rate of 62%, 3 complete, 15 partial. There was also a good control rate, and there are also parameters here to which I would like to draw your attention. For instance, after 12 months, 73% were still alive without progression of the disease, 80% were alive. These are much better parameters for this disease than we would have expected with chemotherapy alone. Much, much better. So the conclusion here is a chemotherapy-free strategy with a combination of nivolumab and low-dose ipilimumab in this population called MSI-high stomach cancer or gastroesophageal junction cancer showed a high and robust efficacy. And additionally, I have to say it showed a good tolerability without the toxicity of chemotherapy. What does it mean for everyday treatment? Beyond HER2 and the PD-L1 status, which are part of the routine assessment, I showed that in the study which I presented before, physicians should also check for the microsatellite instability status. Even if this is a relatively rare condition, less than 5% of the patients with metastasis, patients with MSI-high gastric or gastroesophageal junction cancer should absolutely receive immunotherapy as early as possible, combined with or even without chemotherapy. Currently, the approval is rather in combination with chemotherapy, but we see here first results that potentially in the future we can withhold chemotherapy or give it just very short or serve it for later lines of therapy. That's it for this very small, but in my view, very interesting study.
Thank you, Florian. It shows definitely that biomarkers are important to personalize the treatment. And as you have mentioned, although in only 5% still, if a patient has this marker, should receive the proper treatment. And I think it's really interesting that chemotherapy, which is usually the backbone of all cancer treatment, here is not given. Do you expect in future more regimens without chemo, or we are not there yet?
It's a bit difficult to speculate on that because traditionally we need chemotherapy to kill a lot of the tumor cells that we have in front of us for stomach cancer. We have some other diseases, not stomach cancer, where we see more chemotherapy-free regimens. But for stomach cancer, we still have not so many markers, such as MSI-high, who really qualify our population being highly sensible to a non-chemotherapy treatment. So to be very honest, I believe that majority of patients for the next years will still need chemotherapy as a backbone, but complemented by additional treatments which have their effect, and in some very small subgroups, such as the MSI-high subgroup, even without chemotherapy.
Thank you. I suggest that we move on and go to the next study.
Absolutely. And this is another new biomarker that I would like to introduce to you that will play a role, maybe not this year, but certainly next year, when hopefully approvals for a new targeted treatment will be done in Europe and also on other continents. I'm talking here about Claudin 18.2, and I'm talking about a drug which is called zolbetuximab. It's an antibody which can be given as an IV infusion, which is directed against Claudin 18.2. Claudin 18.2 is an interesting protein which is expressed on some, but not all, stomach cancers. We are talking about approximately 40% of stomach cancers that carry Claudin 18.2. It's a protein that was detected approximately 15 years ago. I worked very closely to the people who detected that group, research group from Mainz, and they found that Claudin 18.2 is a protein that can be found in the normal stomach, not typically in other organs. So it's very typical, specific for the stomach. And when a cancer occurs in the stomach, at least 40% of them also carry this protein into the cancer. And so it becomes an interesting treatment target. It's relatively simple to detect Claudin 18 expression. It's a test that can be done in every pathology. We call it an immunohistochemistry test. We can stain these cancers for Claudin 18.2, and we get the information on Claudin 18.2 positivity within 4 to 5 working days. So there are not many obstacles now. The most important thing is the question, does zolbetuximab work in Claudin 18.2 positive cancers when it is combined to standard chemotherapy? And this was investigated in 2 global randomized phase 3 studies. I had the honor to present one of these studies at the ESMO Congress, where zolbetuximab was combined with Capox. This is a combination of capecitabine. It's a chemotherapy drug that one can take orally, and oxaliplatin. This is an infusion-based traditional chemotherapy. So what you can see here is that in this GLOW study, there was another one which is called Spotlight, which also involved 500 patients. In the GLOW study, 500 patients were involved, and they received on a randomized basis either Capox and placebo or Capox and zolbetuximab, so the combination of an antibody and chemotherapy. And what we reported now is the primary endpoint, which is progression-free survival. So the survival time of a patient without that the disease progresses, and also the overall survival of these patients. What you can see here is that both progression-free survival and also overall survival were longer with zolbetuximab plus CAPOX. When you take a landmark after 2 years, 24 months overall survival rate, there were 10% more of patients who survived 2 years, which we find quite meaningful for this very aggressive disease. And when you are asking what was the price, what were the disadvantages of adding zolbetuximab to CAPOX, it was mostly in the field of gastrointestinal side effects. So unfortunately, patients who received zolbetuximab experienced more nausea and more vomiting, also decreased appetite, which is, of course, an unwanted finding. However, we must say that the majority of patients who experience these side effects experience these only during the first weeks of treatment. And then there was a certain adoption to this antibody, and the appearance of vomiting and nausea became much less. But this is important to know. So we see endpoints which are improved. Zolbetuximab plus CAPOX lead to better progression-free survival and overall survival. Safety of this treatment is relatively high, but we need to be aware of nausea and vomiting. The approval agencies, both in North America, the FDA, but also in Europe, the EMA, and also the ones that are responsible for Asia, are currently taking a look at the files that were submitted there. So we hope that approvals will be done within the next couple of months, and that then we will be able to treat patients with zolbetuximab. But importantly, the first step is to look at the Claudin 18.2 expression. So another example that a biomarker will be important to tailor treatment and may lead to an optimization of a personalized treatment. Maybe I show you this in conjunction with the last small evaluation of the studies that is focusing on quality of life. We presented this as a poster that also got a lot of attention because, of course, colleagues are interested in knowing if this antibody comes now into clinical practice and this antibody is causing more nausea and vomiting in some of the patients, would it have a negative impact on quality of life compared to standard treatment? And this is what we reported, and I'm just showing you here that in this study we combined data from the GLOW study that I presented before and the other global study, Spotlight, that had very similar outcomes. And we can see here, I'm not going in all the details, but for the major domains of quality of life, such as global health status, physical functioning, abdominal pain and discomfort, and nausea and vomiting, we did not see important difference between the zolbetuximab and chemotherapy-treated patients and those treated with placebo and chemotherapy. We see some difference in nausea and vomiting during the first weeks. The blue curve compared to the red curve shows more nausea and vomiting within the first week of treatment, but this becomes less important after some weeks of treatment. It's important to know that and to have a good management of that, but there is no general deterioration of quality of life when this antibody will be used in clinical practice. So I think I showed you everything. I don't need to read you through all the informations here, but what is important for clinical practice, I would like to highlight that we need to inform patients about potential side effects. We always need to do that. to tell patients clearly and truly what could be expected. It's very important, in my view, for the safety of the patients to know exactly what could happen, what are alarming symptoms. And here we need to inform them, especially about nausea and vomiting during the first administrations of the antibody. We also probably need to motivate patients to go through that phase and not just stop the treatment. And we need to make them aware that after the first or second administration, these side effects will most probably become better. We can expect that tolerability gets better with longer therapy and that important quality of life domains are not compromised, but there may be some important differences in the prolongation of life in postponing progression of the disease. So that's it for the last instrument that will be new in the treatment of stomach cancer.
Thank you, Florian, for presenting this data. I feel it's really important that aside from presenting the overall survival and survival data, progression-free survival data, that we or you as the experts present at the conference is also quality of life data for patients, because this makes it easier for them to decide on the treatment, whether they want to take it or not. And as you have mentioned here, what you see, the side effects of the nausea and vomiting are present in the first couple of cycles, but overall do not impact the quality of life. And it's really important that you discuss side effects of the treatment with the patients. And I wanted to ask you, from your experience, how do they usually react?
I would say that by itself, many patients come already with the experience that chemotherapy will impact on how they feel. There is very few patients who do not know anyone who has already received chemotherapy, and many know that this is a kind of treatment that has side effects. So there is already a relatively high expectation that something will happen to them, something unpleasant will happen to them. So sometimes we really have to encourage patients to try it and not to give up from the beginning. And we need to weigh these potential side effects against the potential benefits of treatment. I think that's the most important part of the discussion. On the one hand, to say that meanwhile, we have a lot of possibilities to fight against side effects. For instance, to give things prophylactically, not to experience nausea and vomiting or some other side effects, or to help when side effects occur, and also to tell that despite side effects will occur, may occur, or will occur, still there are important benefits of treatment in the control of the disease. Because finally, what we really see and what studies also are showing, the quality of life importantly also depends on the control of the tumor disease. When the tumor is uncontrolled, when it continues to grow, when it continues to make symptoms, for sure, the quality of life will be impaired. And with the treatments that we are giving, we can do something against the progression of the tumor, which has an impact on quality of life. So to explain patients this balance between that, on the one hand, we have to harm to do something beneficial, on the other hand, is often a very important part of the discussion.
Thank you. Thank you. And I hope that clinicians that are also probably listening to this are discussing this with their patients, and also that patients are seeking additional information if they are not getting or if they are not understanding. And just to conclude, because I think this is really important, can you just list once again the biomarkers that are important in the treatment for this patient population what is the testing that needs to be done in order for the patients to receive the most optimal treatment for them?
Yeah, this is very important. Thank you for asking that. Now and today, we need 3 biomarkers. It's HER2, it's the expression of PD-L1, and it's microsatellite instability. We need that upfront and from the beginning. Tomorrow, probably already next year, in addition to that, we need Claudin 18.2. And everything which goes beyond that is currently investigated in the framework of clinical studies. So patients are always welcome and invited to take part in that because beyond these biomarkers, other novel targeted treatments or immunotherapies may become available based on even more biomarkers that are currently assessed.
Thank you, Florian. Thank you for this very interesting discussion. I hope that we have managed to give a brief snapshot of the most important presentations from ESMO 2023. It has been a pleasure discussing this with you, and I hope to see you next year.
The pleasure was on my side. Thank you very much, Zorana.